Good morning, everybody. It gives me great pleasure to have this session on management of oral cancer in the COVID-19 pandemic. The speaker is none other than our own Satheesh Prabhu, who is there in the Oxford, UK, and it is also a matter of pride that both the moderator and the speaker are stars of GDC. Welcome both of them. I would like to introduce our moderator, Dr. Abhay Datarkar, who is heading the Department of Microvascular Surgery and has got many accolades under his belt and would continue to do so in the future. He is in an official position, and he has got innumerable awards and publications to his credit. This would go is endless, but I have to hand over the proceedings to Abhay so that he can introduce Satheesh and begin with the program. Go ahead, Abhay.
Thank you, sir. So thank you so much for a lovely introduction. At the outset, I would like to thank Central India Academy of Oral and Maxillofacial Surgeons, our own Dr. Shenoy sir, who is the president, and Dr. Varsha Manekar, she is the secretary. She will join soon because she is in some other meeting, and obviously Dr. Vrinda and Dr. Madhumati. Like I have been given a task to introduce our speaker for today, Dr. Satheesh Prabhu. You know, like Satheesh, and Satheesh actually doesn't need any introduction. Everybody in India knows Satheesh very well. And still, I introduced Satheesh. Satheesh has done his graduation both in medicine and dentistry. And he is a recipient of Leibinger Fellowship from the European Association of Maxillofacial Surgeons and advancing the Specialty Award for International Association of Oral and Maxillofacial Surgeons. And he has done his postgraduate certificate in medical education. And his keen areas of interest are head and neck cancer surgery and salivary glands and mouth and lip and facial lesions, TMJ disorders, and obviously facial implants and zygomatic implants. The best thing what I would like to tell about Satheesh is Satheesh was very instrumental in getting an scientifically affiliated association with European Association for Craniomaxillofacial Surgery when me and all the members of the Nagpur, Dr. Shenoy was the chairman. We did a conference in Nagpur in 2017 and which I hope everybody joined and it was a grand success. Thank you, Satheesh, for that lovely affiliation with EACMFS. And with this, I request Dr. Satheesh. And one thing about Satheesh is me and Satheesh, we were the contemporary while doing the post-graduation. That is the closest bond what we have with Satheesh. He is our GDC Nagpur own product. And he have a lot of affection towards the GDC Nagpur. Thank you for that. With this, I request Dr. Satheesh to start his presentation on management of oral cancer in COVID-19. Thank you so much.
Abhay, just 1 minute, Satheesh, before you start.
Right, sir.
Can we have it on record that it's about 6 o'clock in the morning?
Right, sir.
Yeah, so that's off to Satheesh for agreeing for this program and doing it, at 6:30 GMT, so that we can have it at our management of oral cancer. Thank you so much.
And I would like to welcome our own Dr. Vinay Hazare sir, ex-Dean of Government Dental College and Hospital. Sir has also joined, sir. Thank you so much for joining. And thank you all for joining. It's almost houseful today now. Thank you so much. Satheesh, please start your presentation.
Thank you. Thank you very much, Rama. Thank you, Abhay. And thank you, everyone. You guys have been fantastic in my career. Just to sort of give you a couple of minutes, couple of seconds to sort of highlight the importance of it. I think we are never complete as a surgeon. We always learn, and the learning process started quite early on, back in '97 when I joined my MDS in Nagpur, and since then it is still continuing, and the love and affection from Nagpur is quite important for me. Thanks for asking me to share my experience. The world that was there in 2017 to what it is today, two different worlds. I'll try my best to try and speak louder so that I can overcome the background noise.
Yeah, I'll mute it.
Thank you. So the world is a different place. In the last 6 months, it has changed drastically. And we are in the middle of a pandemic. And one of my patients told me, we don't get to choose the cards, we only get to play. And this is the card we have got now, and we need to play it right. And we need to play it well so that we can come out of it successfully. Not all solutions fit every healthcare system. All the healthcare systems, whether you say it's a developed world or developing world or poorest of the poorest healthcare system, all those health systems are on their knees. And I have no shame in admitting that UK has gone through a very rough time, and it is still trying to keep its head up. That is the situation across the globe. So as medics, we have the responsibility to share our experience and try and make it better for the next wave that is happening somewhere else in the world. Now, what is our role in this pandemic? As a cancer surgeons, we don't directly deal with COVID patients. You might be dealing with it in the sense you might be redeployed and you might be dealing with COVID patients at the front line. But as a general view, we are not very clever to look after a patient on an ITU, but we might provide a tracheostomy to these patients when needed. But we have a slightly different role in this pandemic. Now, I want to draw your attention to the deaths that we are having. Now, every day you are seeing the number of deaths recorded in every country. The Johns Hopkins does a great job of providing that data to almost every corner of the world. Now, on the top bar, you will notice that it is tested positive for coronavirus and they have died. Now, this is the UK, and this is on the 1st of May. Now, the number of people who were tested positive and then unfortunately went on to die, that is in the top bar. But then there is another way of measuring the deaths. That is, not just they were tested positive, but also they had death certificate that mentioned COVID-19, i.e. not necessarily they were tested for COVID, but they had signs and symptoms of COVID, and they were given the death certificate with COVID as one of the causes of their death. In UK, all these deaths are recorded. And then there is a third way of measuring it. That is by looking at the average death during this period of the year over the last 5-year average they take, and they compare it to the deaths that is happening now. And you can see that it peaked a lot in April and May, and that was about 50,000 additional deaths compared to the average death time. And the reason for that is not just the COVID, but what we call the collateral damage. There is never ever a good time to be ill, but definitely not in a pandemic. And if you have patients who have illness like cancer, not necessarily they get the best treatment in a pandemic. The healthcare system is rationing the care that it can provide. And very likely that we will see more and more deaths, not related to COVID directly, but indirectly. And that is going to happen across the globe. And UK is not an exception. And when people say, one country has got a higher death number than the other, there are lots of factors that is taken into account, how we measure it and what is the transparency and the technique. Everything does vary. And our role in this pandemic is not necessarily to reduce the impact of, not to deal directly with the coronavirus, but our role is to reduce the the collateral damage that is happening, i.e. reduce the impact on the cancer patients, try and save them so that we can reduce the overall death rate and maintain some element of normality. So that is our role in this pandemic. I want to go back maybe a few months now, I think 4 or 5 months back, when this was still a very new disease. It is still a new disease. 6 months is not a lot in the dynamics of learning a disease. The attitude and the image that was projected about this virus was quite, when we look back, we laugh at ourselves. There were some who were saying this is just a flu. And there were some saying this is a disease that's happening in the Far East. It won't come to us. The West were thinking we have one of the best healthcare systems that we will manage this. And nobody say in January thought that this is going to happen. The world will be will be locked down. That was, a bit of a shock to every possible healthcare system. And this is I was looking at some of the headlines and people were rushing around to say we need ventilators. All of a sudden there was a huge rush to buy ventilators. Every Formula One company was trying to make ventilators rather than engines. Dyson, which makes the vacuum cleaner, and they came up with the ideas of making ventilators. And just to sort of give you an idea, soon we realized that ventilation is not the answer for this condition. And essentially, we were still learning about this disease. We did know that this is a disease that was killing elderly. And this was a disease that was unpredictable in its nature, in the sense, out of the, nearly 10% of them were getting hospitalized, another 10% were symptomatic, but the remaining 80% essentially were asymptomatic, didn't even know that they had. So it's a wide variety of presentations. Some had just some skin rashes, and they just had COVID, but somebody had loss of taste and loss of smell, nothing else. So it became, it's still a mystery. We still don't know. And in that background, we were dealing with head and neck cancer. And we are still dealing with it. And there are some specific issues that I would like to highlight at the beginning. The head and neck cancer, we have some tumors where we have the option of chemoradiotherapy. Oropharyngeal tumors, those especially with P16 positive, we do know that they have a better outcome or even or equal outcome with regards to treatment with radiotherapy and chemotherapy rather than surgery. And these patients, was quite relatively easy to transfer them to chemoradiotherapy pathway rather than to operate on them. However, oral squamous cell carcinoma, they don't respond well to primary radiotherapy or primary chemoradiotherapy. The other set of tumors, the salivary gland tumors, again, quite limited to oral cavity and to the major salivary glands. They're also rather resistant to chemoradiotherapy. So these tumors do need attention, surgical attention. The other big problem we have from oral cavity point of view or oral squamous cell carcinoma point of view is that they have a very short tumor volume doubling time, i.e. they grow very fast. Few tumors, if it's an adenocarcinoma, they can wait a couple of months, but an oral squamous cell carcinoma waiting for 2 months is too long. Other issues are, operating on an oral squamous cell carcinoma is a long surgery, 8 to 10 hours, if you want to do the treatment in an appropriate gold standard way. And also we are dealing with airway manipulations with high risk for contamination, a tracheostomy or a nasopharyngeal intubation, nasotracheal intubation. All these procedures are high risk procedures. They are aerosol generating procedures. When it comes to treatment of oral cancer, reconstruction is almost an integral part, whether you do a free tissue transfer or a pedicle flap, but you do need some form of reconstruction, and most of the time they are quite complex. And we are dealing with a high-risk patient group. Most of our patients are male, because smoking is predominantly male, especially in the Eastern healthcare system. And we also have an age group that is in the sort of 60s and 70s. We know that the death rate is quite high with COVID in this age group. The other important thing that we need to be aware of is that managing these patients need high-end resources, i.e., a long operating theater, critical care post-operatively. So these are the things that we need to be aware of. The other important thing is risk to healthcare workers. We knew from Wuhan and early on in Italy and even now in UK that there is a high risk for healthcare workers, and the colleagues that we have lost were mainly working in the head and neck area. I'm sure you will recognize the gentleman on the left, Dr. Van Lang, the colleague who raised the alarm to say this is a dreaded disease, it is quite dangerous, who was put through the politics rather than supporting his medicine. And we lost him to this dreaded virus. The next set of photographs are colleagues in UK that we have lost. And it is the same story in most healthcare systems, Italy, Spain. Speaking to my colleagues in the European Association, we all have lost some colleagues, but most of them were, especially in the medics, it is ENT surgeons and dentists, which means we are at high risk. So that is another factor for us to take into account when we are managing oral cancer in this pandemic. If you look at the occupation that is at high risk, you will notice that the dental nurses and dental practitioners are at a high risk to exposure to disease. And also, it is difficult to maintain social distancing in our jobs. So full protection, PPE, is an important aspect in preventing these kind of complications. So the first thing that we did when we knew that this is happening, we were about 2 to 3 weeks behind Italy. I still remember the list that I was operating on a Saturday in early March, I think the 2nd or 3rd of March. It's one of those Saturday mornings that I was operating. And my anesthetist told me he's logging into a lecture. And I had already heard a lot about the ongoing problems in Italy, but there was a first-hand information that was shared by a group of anesthetists in Italy for the benefit of colleagues in UK. And I could see his face turning paler and paler as the lecture went on. And at the end of the lecture, he told me, Satheesh, I don't think we'll be same humans at the end of this mess. And he's so right. After that lecture, I think quite a few anesthetists across UK attended that lecture. And we were on a war footing to get our healthcare system ready for this pandemic. As surgeons, especially for head and neck surgeons, our main aim was to reduce the risk of COVID-19 infection to patients who are at high risk of developing mortality. The other reason that we were deferring surgeries was to divert the resources. We needed the anesthetists in the ITU rather than operating on cases that potentially could wait for another 4 weeks. We needed the ITU beds, we needed the ventilators. So some of the anesthetic machines from theaters were either kept as a backup plan for expanding the intensive care capacity, or intensive care was, the theaters were made into intensive care and used the anesthetic room and the operating room as intensive care unit beds in some hospitals where it went to the peak. The other reason we had to defer surgery was preparation. All the anesthetists needed to be fit tested to make sure they had the right mask so that they're protected. Some of them were only doing the normal anesthetic work, and the intensive care element of it was something that they haven't done it for a while, or they needed a bit more training. And then some of the colleagues were at high risk. They have got their own medical health assessment, and if they are at high risk, they were asked to not to go in the front line. So there were lots of things that was happening, and those things made operating on cancer patients for a period of time, we wanted to defer it. The other main reason we wanted to defer surgeries was to maintain our PPE stocks. Last thing you want is to take out a wisdom tooth and waste a few pairs of gloves and a gown and a visor. It was that precious at that point. Today we are in a slightly better position, but again, you're constantly using up these PPEs and you have to be very careful. So they were the reasons we were deferring surgeries, especially the electives were out of the question. Osteotomies and various other operations were just stopped. We haven't done it for a good few months now. But mainly the cancer cases that were happening was prioritized. We'll come to that in a minute. There was a fountain of guidelines that was coming out from everywhere. There were national guidelines coming from the Public Health England, and then the professional bodies like British Association of Head and Neck Oncologists and BOMS, ENT UK. All these bodies were coming up with some guidelines, and these guidelines were changing almost every day. By the time you read and finish it off, you have a new one to read. So that just shows how dynamic the situation was. We were constantly on these Zoom meetings or reading emails and going through the new guidelines that were coming up. What is considered as an aerosol generating procedures. It kept changing, and what precautions we need to change. What is the PPE level we need to be on? These guidelines were changing quite rapidly, and it is still changing. But I think I have found it a little bit more calmer, and there is an element of clarity now. But in the beginning, end of March, beginning of April, everything was, we were not sure, and partly because there is no what we call evidence-based practice, because a disease that is only 2 or 3 months old, you can't have a huge amount of evidence. People were treating it as flu, including scientific community, not the politicians. So it is still a chaos, but it was a more chaos than what it is now. And there were lots of local guidelines to follow. You have limited resources to handle a major incident, and you are expected to work within certain guidelines to make sure we are doing the right thing. So there is that command and control that was going on. And one advantage we have in UK, I know there are lots of faults in every healthcare system, including the NHS, but one beauty of it is there is one central command. All the hospitals are under Public Health England, and if a guideline comes, it trickles down to the last individual. So there is that command compared to quite a few healthcare systems where there is no reach to all the hospitals. There is one big private company that will own about 200 hospitals, but not necessarily it will cover all the hospitals. So that way, NHS was in a slightly better position. Our guidelines that were coming out were mainly based on what was happening in Wuhan and Italy, and that was sort of an experience of 2.5 months. This was sort of middle March. The peak in UK was 8th of April, We lost about 1,400 people on that day, and that is considered as the peak. And during that period, end of March and beginning of April, we had canceled all the elective procedures. Procedures like sentinel node biopsy, we had stopped. We avoided free flaps. We did do some, we had a patient who had a T4 but N0 neck, a large mandibular tumor that was coming out of the skin, but she did not have any radiological evidence of nodal disease, which means she has a better prognosis. All she needed was a resection of the tumor and neck dissection and a reconstruction. Very likely that she will not need radiotherapy. So yeah, we did do cases like that where the outcome is better. If she had any neck disease, unlikely that we would have operated on her. So free flaps were very few, but we did still do them. If it is a very small T1 tumor, we were just monitoring the neck rather than doing a neck dissection, which means you take out the tumor, it's a day case procedure, and they go home same day, which means that exposure to risk is limited. Those oropharyngeal tumors that were amenable for treatment, and they went for chemoradiotherapy. And whenever there is a chance to avoid tracheostomy, we avoided it because it was considered as a high-risk procedure. We know that this virus tends to live in the bronchial tree and the nasopharynx. So any manipulation in that area was considered as a very high-risk procedure. We did not have this evidence when we were planning. This evidence came out from COVID surge in early April. Sorry, not early April, I think end of April. And this is a sort of reinforces what we knew and also gives a number to it. We knew that if patient catches COVID, it's not the right thing and it can be dreadful. But we did not have a number to claim or explain to patients what was that risk is about. And also to balance the benefit of operating and not to operate. There was no number for us to compare. But this COVID surge, which is a fantastic initiative, it's an observational study, it's a multi-center cohort, and they looked at the surgeries between 1st of January to 31st of March. And they were mainly looking at the 30-day post-operative mortality. And also the secondary outcome measure was pulmonary complications. They were mainly looking at patients who had emergency procedures, laparotomy that came in as an acute abdomen, and neck or femur fractures, then RTAs. Head and neck procedures only formed a very minority of it, only 5%. So it's not a strong evidence for head and neck cancer, but it just gives you an idea of what would be the mortality if you're operating in a COVID infected patients. There were about 1,100 plus patients, and nearly 74% of them had emergency surgery. A small group of them were elective procedures as well. Remember, this was the beginning of January to 31st of March. And preoperatively, there was presence of COVID in 26.1% of patients. The numbers are quite staggering. The 30-day mortality was nearly 25% of them died. And the pulmonary complication was there in about half of these cohort, which means, there will be, even without COVID, there will be a mortality and pulmonary complications, but this is quite staggering, 50% of them developing pulmonary complications. The overall conclusion was that pulmonary complication affected half of those operated with SARS-CoV-2 or the COVID infected patients, which is quite high. And hence, they were suggesting that we should avoid any procedures in patients who are above the age of 70 and those who are male. We know that there's a male preponderance in mortality for COVID-19. So that was an evidence that came out that we could put a number to and say, this is the risk. And if I'm telling a patient, this is the risk you carry if you do catch COVID. And hence, based on that, we were sort of, And of course, we did that action of deferring deferring procedures even before this paper came out. But it made it more easy for us to understand and to explain to patients that the postponement of non-urgent procedures was important, and also delay or avoid the need for surgery and promote any non-operative treatment. So that are the sort of reasons we were deferring surgery. Now, at this point, before I go any further, I'm happy to take questions, Abhay, if you have any.
Hello.
Hi, Abhay. Yeah.
Yeah.
I'm
Sir,
happy
any
to take questions.
do you got, Shanoy, sir?
Or do you want me to carry on?
Yeah.
Hello.
Sir.
Yes, please go ahead.
Okay.
Satish, please continue. Okay.
Okay, thank you.
Satheesh, just one request. Could you just get closer to the mic?
Sure. Can you hear me any better now?
Yeah, that's better.
Okay, thank you.
If there are any questions, please feel free to ask, or you can put them in the chat box. But they'll be asked in the next session. Satheesh, you please continue.
Thank you. So what we do know from the mortality rate, you notice that at the age of 70, the graph tends to go up. And that is a significant thing for us to remember when we are operating. If you have a patient that is at the age of 70 plus, you need to be extra cautious in what you're doing. So the next part of the lecture is about our experience in Oxford. I'm not saying this is the right way of doing it, or this is just to share our experience so that you might be able to use some of it, because I'm very much aware that the healthcare systems are different, and I do appreciate the hard work you guys do, even without it being in the pandemic. I always say, Abhay, that what you guys are doing in the given resources is amazing, and I take my hats off to you. It's really humbling experience, for somebody to see that. Having worked in India, I do know the effort and the logistics that is needed to do an operation, and the plight of the patients as well. So this experience is not to say we have done well or bad. It is just to share what has happened. We are fortunate to have 3 hospitals in Oxford. One on the left is the John Ratcliffe Hospital. It's a fairly large hospital. It's an acute hospital where there is an emergency department. It had about, to start off with, there were about 60 or so intensive care unit beds, but it was increased. The capacity was increased. I think they nearly tripled it within a couple of weeks. So that is the hot site. So all the COVID positive patients were kept in the hot site. They canceled all the elective procedures, and they only kept some emergencies. And that, it's a fairly large hospital, and they tried to keep a layout that was hot and cold even within that hospital. The one on the right is the Churchill Hospital. That is my base, and that is essentially a cancer hospital. We have our own radiotherapy facilities. Most of the oncology aspect of most of the anatomical areas, like an upper GI, lower GI, hematology, all these specialties are based in this cold site. Unfortunately, we have this luxury of having 2 different sites to manage this pandemic. The significance of it is, I'll come to that in a minute. We normally see about between 150 to 200 new oral cancer cases, and we operate on about 100 patients or so in a year. That's a sort of volume that we do. By no means it is anywhere closer to some of the big cancer centers in India. But obviously, UK has an oral cancer rate of about 7,000 new cases in a year. And also, it is the 9th or 10th cancer in the cancer league table compared to India, where it is the 1st or 2nd, and depending on what data you follow, but it is a very a different setup. Now, when the lockdown happened, that was on the 23rd of March. I think it was the same day as India, if I'm not wrong. The first lockdown that was announced in India coincided with UK. The dentists were ordered to shut the services. It was only emergency, and very few dental emergency centers were available to access, which means the referral for oral cancer went down. 50% of our patients come from dentists. That's mainly because every 6 months, patients go for their checkup and they catch the cancers early. So we have a very, I would say, when I look back, I think it was a very good system where patients were being seen every 6 months and cancers were caught reasonably early. But still we had T4 tumors. That is because only maybe about 40 to 45% of the population don't have a dentist to visit every 6 months. So that is the sort of a background for this. So essentially, we were seeing very few referrals for oral cancer. So I would say about only 30% of the normal, which is worrying because as soon as, which we are seeing now, an increased surge in referrals and also fairly large tumors. And we are still not only the dentist opened last week, so we are already seeing a surge in referrals, but also we have already seen a couple of patients already in the last 2 weeks who were inoperable. So that is the impact that we are sort of realizing, and this is the sort of background to it. Whenever they were referred, the most of the consultations were, or shall we say, even now, it is telephone and video consultation. And it is, it's a slightly strange kind of a feeling. To examine somebody on the video is not that easy. And we do ask them to send some photographs, and which is a bit more easier and a better clarity pictures. Once we have seen the photographs and we have done the initial consultation, we try and bring them into what we call one-stop clinics, where we are able to clinical exam, carry out the clinical exam, and then we send them for a scan. We try and book it on the same day, and also do the biopsy at the same time. Obviously, we do make sure that we have the appropriate level of PPE, eye protection visor, and FFP3 mask, and gowns to do these exams and to carry out the biopsies. We try and give them as much information as possible through booklets. My clinic time with the patient is very limited. All I need is to examine the tumor and I keep it to minimum. Especially this was the case when we were in the peak. I'll come to the peak element of it in a minute, but importance is to reduce your risk and reduce the risk to patients and keep all these appointments to minimum. If they're coming to hospital, try and do all the investigations that you need to do at the same time. Every time a patient comes to hospital, they are exposing themselves to the risk, and also you are exposing yourself to the risk. So you're trying to reduce that. And also, because they don't have that a long consultation that we normally provide, we try and give them access to support. Like we have a fantastic Macmillan nurses team who are cancer specialist nurses, who will pick up the phone and give them a call and address any concerns. So we have that facility, and that is the sort of the workup towards getting patients into the system. Normally, we used to have a multidisciplinary team meeting, or tumor board, as the American system calls it. And these meetings, we have it every week. We usually have it on a Thursday afternoon. But now it is almost all on online meetings. We are using MS Teams. Only 4 or 5 of them there in a physical room, but in a socially distanced way. But most of us attended through MS Teams. Even exposing ourselves with other colleagues is not ideal. We are high-risk group. If you're working in a hospital, currently the chances of us catching the infection is high. And if you're gathering in a group of 10, there's a good chance that the whole MDT might be quarantined. So that is the sort of precautions that we've been taking. The other thing that we did was accessing the healthcare records on our laptops. These things were only given, this access was given only to very few, and also it was a long drawn process. And as soon as this pandemic happened, the trust just, within a few days, we all had access if we requested for one, which means, the number of times that I had to go to hospital to do any admin work was less. Cutting the exposure was the key. And all these specialist meetings that we hold, or the tumor board meetings, the discussion was fairly extensive to make sure we give the best in the given circumstances. If you are saying not to do the neck dissection and just do the wide local excision, try and get as much information as possible from the primary biopsy. Could we get the depth of invasion? Is it a high-grade disease? Can we check the perineural spread in that biopsy? If these features are there, then maybe we should do a neck dissection rather than monitoring. So we spent some extra time in discussing these patients. We had to scale down treatment based on the guidelines that was coming nationally. As I said, we were avoiding neck dissections in small T1 tumors, try and keep these procedures to decades and avoid free flaps. Monitor necks in early oral cancer, which something that I stopped doing after Anil De Cruz's paper from Tratas. They said you either do the neck or there was no option of monitoring. Hence, making these changes was a bit difficult. You feel very anxious. What if they come back with a big node? I had operated a couple of sentinel node biopsies end of February, and Murphy's Law, both of them came back with some tumor cells in the sentinel node, which means in a normal situation, I have to go back and do neck dissection. Fortunately, there was no extra capsular spread. They were only, one of them had some few cells and the other one had a 2.5 millimeter deposit without any extra capsular spread. Normal situation, as I said, we would have gone and done the neck dissection, but we decided that we will monitor it and do some serial MRI scans. And interestingly, they both have stayed negative. This is not a scientific evidence, but just saying, it is a process that you have to get used to when you change your practices. You come up with ways and means of preparing yourself. The other thing that we were doing locally, and I think it was the case across the country, was if we are planning to do a major case that involved free flap, the one that I was telling earlier with the T4N0 neck, that lady needed a scapula, some massive skin involvement, and it's an octogenarian with a T4 tumor. Generally, they do well because there is no metastasis in the nodes. So we had to go through this independent review body. There's one head and neck surgeon on it, but there are about another 4 or 5 non-head and neck surgeons, other oncosurgeons in the panel, who will say, independently look through the notes, and you have to present the case, and they will say, is it the right thing to do or not? You have to justify what you're trying to do. Surgeons, sometimes we get carried away. We want to operate and try and save lives, but not necessarily that's the right thing to do. And it's a good idea to have one more person looking at our practice to say, is it the right thing to do or not? And that is, I thought, was a good move. That has now stopped. Now that we have come to some form of normality, we don't need to do that review. We obviously discuss our cases in the tumor board, where we agree what we're going to do, and generally there's a consensus on the treatment plan. When we do book the patient, we need to justify on this piece of paper to say, what type of surgery we are doing. Is it something that we need to do within 24 hours or 72 hours? And if it is an elective kind of operation, including the cancer, is there an expectation of cure? And can it be delayed by 10 to 12 weeks? So this helps to prioritize the workload that we have. And again, the question is this with a curative intent? If it's a T1, T2 tumor, no nodes in the neck, then the curative chances are more than 50%. But if there is a positive node, it's 15 to 50%. So that is how we were sort of categorizing our caseload. And then also we need to check what happens if this patient gets COVID-19. If they are fit and less than 70-year-old, it may not have a huge impact if they catch. But if they are above 70 with comorbidities, they are likely to have a higher risk of mortality. So we have to fill this form. That will help the admin team to prioritize our workload and say, okay, the next week you can have this lady with, this is the priority. So that is something that we are following. Once we have made a decision to operate, we ask the patient to isolate for 2 weeks. When we say isolate, there's no family visiting them. It's a very critical time in their life, being given a diagnosis of cancer, and they're looking at an operation that could be potentially life-threatening, and they may not see their family again. And we are asking them not to meet anyone. That's a very, very difficult time for patients. Even in normal circumstances, it's a very anxious time. And imagine not having the support of family to give them a cuddle is quite heart-wrenching. We also ask them to go through the PCR testing, again organized by the hospital. So there is a drive-through testing areas for these patients. They come, they do the test, and then they go back home and isolate again. We also used to do CT thorax on the day of surgery. First thing in the morning, 8 o'clock, the patient used to go to CT scan, and then by 8:30, the surgeon used to get a message to say, yeah, CT is clear. Because there were some classic signs of COVID that you can pick up on CT thorax. But then we found out by end of May that the specificity and sensitivity of that was not clear. And it also doesn't tell us whether it's an active disease or not. Once we had the PCR test, and that was widely available by end of April, we stopped the CT thorax almost immediately. So that is the sort of pre-operative preparation that we've been doing. It's very important to understand the peak of this pandemic, where you're living. The peak in UK was, as I said, end of March, beginning of April. And at that peak, there were about 2.25 million people who were infected in the community at a given time. Don't get fooled by the numbers that come up every day from the Johns Hopkins. If they say, definitely this is the case in UK. If we were seeing, 1,000 new cases, which is the case at the moment, about 1,000 new cases are diagnosed every day. But the real number, which is again calculated using statistics, and there are some very good apps which I will share with you in a minute, where people are uploading their daily symptoms and all. And nearly 4 million people are putting the information in, including myself. Based on that, statistically, there are about 3,500 people getting infected every day in the UK. I'm sure there are some numbers that could be worked out for each country. I'm not a clever statistician, I'm a very simple surgeon, but it gives you an idea that the numbers out there in the community is much different to what is there on the newspaper. So we had about 2.25 million people. This is, again, an estimate. a rough estimate. So when you have that peak, if you pick up 10 people from the street and operate on them, there's a good chance at least 2-3 of them will be COVID positive. And if you can defer your operations during that peak, and if you know when it is going to come, then you can defer your surgeries and interventions during that period, and then operate on once the peak comes down. Remember, this is a transient disease. It stays in the body for roughly 2 weeks, and then they are reasonably safe. We still don't know what the impact is long-term on these patients, which I'm sure there will be some, and we're still learning, but at least you have avoided infecting more people by avoiding patients in that peak. Okay. The other important element of our process is having appropriate PPE. As I said, this has been a bone of contention across the globe. When everybody wants it, every healthcare system wants it, the prices of it went, 8 times, 10 times the average price. I don't know how these people were sleeping at night when lives were lost, especially of medics. So it is an important aspect in what we do. So make sure you have the appropriate PPE, but more importantly, how to use it. Still, washing hands and avoiding touching the face is an important aspect, not just for a general public, but also for all of us. It is important. It's a life and death, in my opinion. We've been fortunate in Oxford, and I'm very grateful to my trust for providing me one of the best PPE that I can have. So we all have been given respirators. Majority of the workforce, I would say, where they have a good fit, have been provided with these respirators. The initial one that I got was this, what we call a 4-stem. These are filters that we need to change every 28 days, and we clean that with the cleaner wipes and antibacterial wipes, and it is got a very good track record. Filtration is very good, and we change the filters, and it's good to go. But the things that we do, like using a microscope, this is not a very easy respirator to wear. And I just told the trust, and they've given me, something wearing this kind of thing too. They've given me one more that only covers my nose and mouth. Called a Force 8 respirator. Again, it's a similar concept of filtering, and gives a good tight seal. And that is the protection that I have. But just having that doesn't solve the problem. It does come with its own problems. Communication is a major issue. We'll come to that in a minute. Now, we might think, yes, we have gone past the peak. We are doing well. We have a reasonably safer now. But patients, they still see the fear. They are still very anxious. Imagine if these slides are coming up almost every evening on their television to say 381 patients in hospital have been tested positive, and another 965 patients have been tested in the community. So automatically, the patients are still worried. I do know that patients who said they don't want to come to hospital, and they don't want to go to John Radcliffe. They want to go to a COVID-free hospital, if anything like that exists. So essentially, we have a different perspective here to address, and the patient perspective. How safe is it for patients to come and have an operation? Just because they have cancer doesn't mean they will come and have the operation straight away. They might do, but we have to make sure that their anxiety is addressed. So I usually tell them, with the graph that I've got on the left, to say, okay, in March and April, the risk was very high that there will be COVID patients in the hospital. Whereas now the risk is relatively small. It's never zero, it's relatively small. Looking at the numbers that you got on the right-hand side, the chances of somebody having a COVID that they don't know is about 1 in 1,000 at the moment in UK. Okay, so which is relatively small compared to beginning of April when it was quite high. Okay, population of UK is about 69 million, 68 million, and just to sort of give you a picture, the population of Maharashtra on its own is about 125 million, I think, if I'm not wrong. So UK population is almost half of Maharashtra. So that is the for you to sort of put into picture. It's a small country. We have also got some very useful information booklets for patients to read. What are the benefits and the risks of the procedure? We encourage patients to ask these questions. What are the risks of catching COVID-19? We encourage patients to ask these questions. And this is the Royal College information booklet for patients. It is something that you can always download it and modify it and use it. One beauty in this pandemic is that the information that is generated, like Lancet and various other publications, have made it free and accessible to anybody. So make the most of it. The other element is staff screening and safety. And I must say, now I'm in a fortunate position where I get screened quite regularly. We are encouraged to have this screening tests. Interesting data for you to know, when we screened in Oxford, all the staff, and there were about 2 to 3% of them were asymptomatic and they were positive. So there's a good chance that these 2-3% would have been infecting unknowingly to other staff members and patients. So screening, test is the right approach. Test everybody, and I get tested almost every week. I try my best to test along with my patient that I'm operating. All my patients get tested. The one I have on Tuesday and got tested on Friday, and I tested myself on Friday as well. We had a high-risk group that is likely to catch the COVID, but also to spread the COVID. Okay, so by doing our bit, by going through the screening, we are reassuring our patients and colleagues. I'll be more comfortable to know that the nurse who's scrubbing with me in theater has had her test regularly and she's clear. Because I'll be spending nearly 6-8 hours in theater next to her, and if she has one, I'm likely to catch it from her. So it's quite important to have that reassurance. I know it's not possible in all healthcare systems, and I'm very fortunate to have this. And that's my sort of a log of tests that I've had. I record it on my app that we have, the Covid19 app. In terms of surgical challenge, if you're operating, especially with the PPEs and the anxiety level within the team, you need to add extra time for your surgical procedures. Neck dissections that normally takes about 2.5-3 hours, add another hour to it. Mainly because communication is a problem. You're working in a very controlled environment. If you need something, the team that is within the theater needs to write it on a board and show it to the people who are on the other side of the theater, will go and fetch it and pass it through a small gap in the door. So it takes time. So all those things are important to know. You have to work in teams, and it's very important to support each other during this difficult times. We normally operate with 2 consultants. One normally does the resection and one does the reconstruction. But sometimes we have said during this pandemic, we'll come and give you a hand. So we were 3 of us. One will do the resection, and another. It's more of a moral support rather than anything else. These are all quite difficult times. We also try and have our own familiar teams. You know, you don't want to have somebody who is new to in the operating room, because with those kind of respirators and masks, it's not easy to communicate. And if you have to tell what you're going to do next for every step of the procedure, you'll be fighting a losing battle. So communication is a fairly large problem when you're wearing these respirators. Another important thing is make sure you drink enough water. Okay, you'll be wearing your PPEs for a long period of time, and you don't want to step out and have a glass of water after an hour of operating. You want to try and minimize wastage of PPE. So hydrate well and try and look after yourself. Things like a large pec major here, what you see, in the past I'd put an ALT, but you have to come up with things that will work. A pec major does do the job, but making sure you do it right. Last thing you want is return to theater. Okay, so it is very important that you're meticulous and take that extra effort to reduce the return to theater. Once you have done the procedure, oral cancer, the surveillance is the big important aspect of in managing oral cancer. And we cannot just say operate and leave. It is we have to continue monitoring them. So reduced face-to-face contact is still applies afterwards, and we try and see them only if there are concerns. Okay, we still offer them telephone and video consultation. I still see them every 4 to 6 weeks, either a video consultation or a telephone consultation. In the first year, every 2 months, in the second year of surveillance. So the frequency as such hasn't changed, but most of the time it's a telephone video consultations. But more importantly, I educate them and I take that extra 2 minutes to explain to them what to look for. Okay? And any concerns, they will have easy access to reach me, either through my secretaries or through the Macmillan nurses. And I have a low threshold for imaging. I will do an MRI scan more sooner. Usually we do them 3 months after the completion of radiotherapy or 3 months after the surgery, which is used as a baseline. But I do one more in 6 months or maybe 9 months, just to sort of get because I'm not examining them, getting a scan will just make me a bit more comfortable. And patients do come up with some brilliant ideas. One of my patients went on Amazon and found these non-medical endoscopes. These are mainly used by plumbers who use this camera to look into the drains and everything else where they can't put their head down. So one of my patients managed to find this and said, Mr. Prabhu, I will show you this, see what you think. I don't know whether you're able to see it. Sorry. I don't know whether it managed to come up on your screen. Rama, could you see it?
Satheesh, we're just seeing this.
The dark screen, is it? Okay. Yeah. I don't know what's happening. Let's see if I can. Okay, for some reason it's not happening. I'll see if I can get it in the end. It's essentially a endoscope kind of approach to see inside the mouth, Rama. Apologies that it did not work. I'll see if I can.
Satheesh, can we take some questions at this?
Sure, of course, yes.
Yeah. So there is a question, Satheesh, like you were talking about the PPE.
Mm-hmm.
So how is your experience when especially you are working, especially in the surgeries like the microvascular, it's a long surgery. So how is your experience wearing those PPEs for a longer time? Like that is what everybody will be happy to share, know about your experience.
Yeah, I think the maximum that I've gone was on a patient that I was doing a scapula, and where you have to harvest the flap and you don't have a huge amount of time to refresh, because you have to turn the patient on the inset and do the micro. Otherwise, the ischemic time is quite critical there. So you don't want to waste anything. So I think I've gone on up to 6 hours once wearing that. 4.5 hours, apologies, 4.5 hours. I did manage to get my respirator off, come out of the PPE after harvesting, while the team was turning her patient back on her supine position from the lateral decubitors. I went and changed. So 4.5 hours, that's a sort of limit, I would say. But again, the temperature in UK is a bit more kinder. In India, if it is 45, it's a big challenge. You really have to be careful. One thing that people have noticed is pulmonary edema is not uncommon when you're wearing these respirators and all. I do feel a bit of a sore throat at the back after wearing it for a long period of time. So it's not easy. It does feel, and again, every individual is different. Those who are claustrophobic, they find wearing these masks quite challenging. And I have colleagues who will just after 2 hours, hour and a half, they step out and come back. So it is a challenge, no doubt.
Does it reduces the efficiency of surgeon, like say when you are doing a long?
Yeah. Now, it is something that we cannot quantify to say, but my gut feeling is yes, I'm sure it does. That's the reason I would say add additional time to your planning, in terms of surgery. If it takes you 3 hours normally, add another hour or even more. Don't hesitate, don't rush. That is the key here. You're working in not just the PPE, but the anxiety of it. There are times when colleagues have just said, okay, this is, can I have another pair of hands, please? And people go and, work together. And that's the reason I said, work in teams, have a good support. This is not the time for ego, just to say, okay, let's have another pair of hands, take breaks if possible, and try and do this procedure in the best way possible. But it does affect, no doubt. Your short answer to your question is, I'm sure it does. I can't hear you, Abhay, sorry.
Can you hear me now?
No, yeah, I can hear you now. Yeah.
Can you hear me now?
Yes, I can.
Yeah. So you spoke about the COVID test 48 hours before surgery.
Yeah.
And you spoke about isolation of the patient for 2 weeks. Okay.
Yeah.
So like what is recommended? Like where do you isolate the patient? Is it in the hospitals or they need the home isolation?
Home isolation.
Home isolation.
Home isolation.
And 2 weeks is mandatory?
Yes. We encourage 2 weeks.
Okay.
It is ultimately, I think, we are testing them as well. The reason we are testing them and we are asking them to isolate is, it is a cancer surgery, and if they isolate, and if they're not isolating properly, and if the test comes back as positive, then it will defer the surgery by another 2-3 weeks.
Exactly.
Yeah. So
that will delay the surgery.
Yeah. And that's the reason.
And do you have the access to the rapid testing in the UK at the moment? Like at the moment here, all PCR tests are done, but we don't have the rapid test. Basically, those for the rapid testing, probably it will be available in a couple of months. We don't know here in India. What is the say in UK? What is the situation in UK for those rapid tests?
Yeah, it is coming. We have got it in one of the hospitals that I work. There is a rapid testing in the accident and emergency. The capacity is about 90 tests a day. That's all they can do. So that is one limitation, and two, the reliability of it is, it's not as
specificity and reliability.
Yeah. So there are the two things. But again, this is an evolving science, and I'm pretty sure it will be more specific, and also we will have a good sensitivity in the near future, and things might change, starting from airline industry to pubs and cafes, they will be keen to have this kind of test to say, look, yeah. But I think the reason for isolation is to reduce the chances of them catching it and deferring the operation. Yeah.
Exactly. Satish, you spoke about to avoid the tracheostomies whenever you can avoid it. The question is if you really want to do an tracheostomy, what are the guidelines do you recommend? What is the care to be taken at the time of doing the tracheostomy, and especially maintaining that particular tracheostomy post-operatively or in the maintenance period of the tracheostomy?
Yeah. So there's a very good guideline that has come out from ENTUK and various other bodies that are now working on these tracheostomy groups. The main aim is to reduce the aerosol.
Exactly.
Okay, so that is the main thing. And number two, if it's a difficult tracheostomy and you have to make sure you got the right skill, and what you have done is 2 consultants for all tracheostomies, especially for COVID, because you're wearing a PPE, the communication is a problem. It's a time-dependent procedure. You only got a minute or so to make sure the tube is in the right place and it's all clear. And then you don't want to scope with your eyes. You have to use the stacking system. You want to try and maintain the cuff so that you don't puncture the cuff, so that when the cuff is below and when you make the window, there is no air spluttering out from the trachea. So there are lots of little guidelines, they try and avoid ventilating when the window is open so that there is no aerosols generated. So there are lots of little tricks that they have adopted to make sure the risk is reduced. But bottom line is, if you can avoid it, you should.
Abhay, can I ask a question? In the meantime, I have sent 2 questions.
Sure, sir. Sure, please.
So Amit wants to know, would you get a HR CECT done a day prior?
Yeah, CT thorax, you mean, yeah. We used to do that. I don't know if you've seen the slide before. We stopped doing it end of May because the evidence was very poor. It's not a high sensitivity or specificity. We also don't know that that disease is active or not. That the changes might persist even if the patient has already had the disease and they have antibodies. They're not infecting anymore.
Rahul, there's Rahul Thakkar from Vadodara. He has raised his hand. Rahul, would you like to ask something?
Yeah, can you hear me?
Yeah.
Yes, Rahul, tell me.
Yeah, Satheesh, I think I joined a little late. You did tell that you would operate on patients who are COVID positive. So far, we have not been operating, but we have now had the opportunities to patients have shown somewhere they have a COVID positive. Now they are coming back for a second opinion regarding surgery. So the question is, this patient requires a free flap. How safe is it to go in, after now about 3 weeks, of isolation, and then they are negative for the RT-PCR done twice?
So first of all, no, I haven't said we have operated on those who are actively COVID. We haven't.
Okay.
In terms of those who had COVID before, no. The patient that I have operated on, somebody who did have COVID before, she did well. We didn't do free flap. We did a PEC major, but we did not have any antibody tests on her to say she definitely had COVID. But her APTT and PT was deranged.
Okay.
And it was quite obvious that it looked like that she had COVID from all the things that was mentioned and that was seen on the blood picture. She recovered well. There was no problems, but she was only 48.
Okay.
So our experience is very limited in patients who did have COVID and where we have done a free flap. But I share your anxiety. What we don't know is how they're going to behave. I think knowing COVID is only chapter 1. COVID and other problems put together is the rest of the book. So
I did talk to my infectious
How many days?
specialist, and he did suggest that with the RT-PCR, it's important to get an HRCT done in this situation. It will help you, you know. So what you said is something very different than what I have been told. So again, it has got me thinking about the HRCT.
Yeah, I think there will be CT changes in the lungs, and what we don't know is how long it persists.
Okay.
And what we don't know is it because of the deposition of hemosiderin changes? It's still not, or is it clots? There's still a lot of learning that is going on. It doesn't look like it's a disease of the lungs as a primary. It looks like, you know, the blood vessels seems to be the case. So we're still learning, Rahul. We don't have a clear-cut picture of the long-term impact of these patients, especially to undergo a major operation.
Can I have one more question for Satheesh?
Go ahead.
Sure.
For these respirators, you know, we've all been doing a lot of research in India. Also, we have been using this half mask. I want to know now, there is some controversy which is the best filter. So would it be a particulate filter, or would be I right now I'm using a combination of organic vapor and an N95. I'm sandwiching. So is that the right thing? What are your thoughts on it? Because we'll see a lot of plume when we are operating. So only a particulate filter probably will not be enough. So what are your thoughts? Is sandwiching is a better way, or only a P100 would be enough?
I think from my understanding is it's N95, it is adequate enough. And that is what we've been following. I must admit this, you know, when they say N95 and various other things, we really don't know how long it lasts and how it works. You know, there are lots of caveats, and also, is it the right fit for you?
Okay.
So there are lots of variables in that. But I tend to go with, and if it has got a CE mark, and the trust has done lots of tests before they sort of bought these. So I'm relying on them. My knowledge in specific to each of these filters is, you know, quite limited, but I do know that somebody has tested on my behalf.
FFP3 is supposed to be one of the best masks. There are guidelines.
No, I'm talking about reusable. So I have one of these, if you can see that. And I have one which is another. I have two respirators. The other one has a sandwich. It's a cassette. And it is a sandwich of an organic vapor and multi-gas and an N95. So it has two kind of filters. This is the regular one. So this I would use it for my minor procedures without cautery. If I'm using a cautery with a plume, I use the other one. So I thought if somebody else has anything else to, you know, share in that aspect.
Sure. Yeah. As I said, I just go with what's been given. But these are all.
There is one more question from Ramya. Sir, should this form of PPE and precautions be the standard of care in future also, even if after the pandemic?
It's a very good question. You know, but again, it's the cost and efficacy of it. How long are we going to carry on like this? You know, it may become that, you know, these filters will become more sleek and more effective because there's a lot of research going on and there's a lot of investment going on in developing newer PPEs. And it may be that we will carry on doing it because, you know, we never want to lower our standards. Once we have reached a standard, we try and continue. So that is likely to be the case. And
sorry to interrupt. Abhay, just a takeoff. There's a question from Stephen Joshua. He takes, now this is a very philosophical question. Seems to be slightly disturbing. He says, do you think this pandemic would come to an end and everything will be back to normal? Is it possible to eliminate it? Even we are when it comes to an end.
Okay. Well, It's an important question. I don't think my views carry any weight in it, but I don't mind sharing it because it's free. I think the pandemic it's not here for a month or two. It is going to be here for a period of time. I don't think it will be over this year. It will be definitely there for next year. I think the answer will be, can we get a vaccine in that is effective? And even once we have the vaccine, the logistics of getting the whole human kind to take it is going to take some time. So the short answer is, I don't think the pandemic is going to get over soon. It's very likely that we'll live with it for a period of time.
So I think we'll continue with the presentation, Satheesh.
Yeah, thank you. So I just want to draw attention to a couple of things before I finish. One is the COVID surge cancer. It's a very good study that is going across the globe. They're looking at the impact of pandemic on the cancer. They're looking at the post 30 days mortality, or if the cancer was deferred, and i.e. they did not operate on them, what happened to them after 3 months' time. So it's a very good study. We are contributing from Oxford. And Richard Shaw, who leads the head and neck part of it, kindly shared some data during a European meeting about a month ago. Nearly 20 countries have participated in it. And the important thing to remember is that because oral cavity cancers are not radiosensitive as such for primary treatment, the number of oral cancer cases was more than 40% in that study, which shows that oral cancer gets priority when it comes to rationing this the healthcare system. There were free flaps as well. Nearly 14% of the work was free flap. That is, half of the reconstruction that was done was free flap. And when it was done in a COVID-free or a cold site, the morbidity and mortality was no different than pre-pandemic state. Okay. And which is what we are seeing in Oxford as well, because fortunately we have this cold site, COVID-free area. Our things haven't changed as such. Outcomes haven't changed. So that is an important message. If you're operating in a COVID-free, or if you're able to maintain a COVID-free environment, and then you should be okay to carry on if you have the resources to carry on as normal. I'm mindful of the time. This is a report, that case report information that we share from the COVID surge. The other important paper, which I will share it to Rama and Abhay, but again, this is something that you will be easily able to access it from the Lancet. This is a paper by Hisham and his big team here. You will be pleased to know that our own Moni Kuriakose and people from Tata have contributed to this paper, Dr. Chaturvedi. Obviously, it's an important consensus paper that I would recommend all of you to read. What's the consensus, international consensus on managing oral cancer, head and neck cancer. These are the associations where they asked the representatives to look at the scenarios and say whether they will agree with this or not. And then eventually they sort of came up with a strong agreement, or a weak agreement. So some of the consensus is on diagnostics. If there is a tumor that is very obvious, and if there is a node in the neck, just doing an FNA or a core biopsy to confirm that it is an SCC in the neck, and if you have an imaging that confirms the primary tumor, then that is perfectly fine to accept it as the diagnosis of squamous cell carcinoma. You don't really need a biopsy, and there is a strong agreement for it, especially if you have to do a pan endoscopy to get a biopsy. So that's a sort of approach they have come. And this is a very useful paper. For example, if it's an oropharyngeal tumor, but if you're just about to take a biopsy under local anesthetic, then they say you don't need a panendoscopy. If you're able to see the images to say the extent of the tumor, it should be fine to make a decision. You don't need to put the patient through a panendoscopy, which is a high-risk procedure again. Again, the oral cancer procedures gets, the priority list comes up quite high up, especially if it's a nodal involvement. You can see a T3N2 oral cancer gets the highest agreement for surgery. In terms of, if you're in a peak of a pandemic, you can potentially delay for up to 4 weeks, but the ideal scenario is that we should aim to operate within 8 weeks from the time of diagnosis. Okay, but do not delay anything more than 12 weeks. So that is an agreement on such things. Okay. If you have to defer a procedure for lack of resources, or if you're in the peak of the pandemic, then you have to sort of prioritize which patient you want to operate. If you have to operate on one, my sort of approach is it going to change the operation if you delay it? And if it is going to change it, then they get the priority. So for example, if somebody with a T1 tumor with a nodal disease, I might wait before I operate on him compared to somebody with a T1 with no nodal disease, because the prognosis is better in a non-nodal disease, and I might as well get him out of the way quickly. Equally, is it going to extend? If it's a tumor on the hard palate, if I leave it any longer, am I going to lose the soft palate, which will compromise the function quite drastically? So that's the sort of factors that I normally look at when I do have to prioritize patients in a pandemic or not. So in terms of screening, I think positive laboratory test alone is sufficient to say that they are COVID positive or not. Now you can see that the chest imaging has lost its position now. In the past, in May, up to May, there was a strong indication for chest imaging. But again, now we have access to PCR tests a bit more than what was the case in April. So in those days, we were doing chest CT. So what can be done? India is a huge country, and every state has a different, they're in a different position, different place in the curve. So maybe a good idea to have some regional working group. It's a good idea to involve an epidemiologist and try and predict the local peak. Try work closely with your other colleagues, come up with local PPE guidelines, and then resource management. Now, that's the case that I'm operating tomorrow, but I think that's of not huge significance. But this is the line that I would say this is a marathon, not a sprint. So pace yourself. Don't expect that it will get over and you want to finish off hard work for the next 2 months when you enjoy the autumn. That's not going to be the case. This is going to take a long time for things to settle or get back to some form of normalcy. So make it a marathon, not a sprint. I'm happy to take any more questions. Thank you.
Satheesh, can you hear me?
Yes, I can. Thank you.
Yeah. Satheesh, there is a question from Dr. Pawan Prasad. Sir, what is your advice for healthcare system where regular screening of the doctors and the nurses is not possible?
I completely understand, and I think the most important part is try and maintain social distancing is the key. Wash your hands, and understand the disease, how it communicates and how it spreads. A hand and a hand towards the face is likely to catch it. So have that extra caution. And most important part is if you have any early symptom, isolate yourself. And that is the least you can do to your colleagues and your patients. And don't hesitate. It's not the bravery of going back when you're still feeling unwell. You're essentially, causing more harm than any benefit. So isolate yourself if you do have any symptoms. That's what I would say. As I said, having a screening is a luxury. Not all hospitals in UK have it. And as I said, I'm very fortunate, but it can't be the reason to be having the bravado of just walking around and doing anything I want. I still maintain social distancing and follow all the basic things that one has to do in a pandemic.
Satheesh, there was somebody called Galaxy Tab A who had raised his or her hand. So
okay, hopefully from planet Earth.
yeah, so I mean, we need to address that person as Galaxy Tab A only. So please
That's
go ahead.
fine.
Satheesh, can you hear me?
Yes, I can.
This is Jeevan here.
Jeevan, hi.
Yeah,
Oh,
Galaxy Tab A is me. Okay.
I know Jeevan.
Okay.
Jeevan, I did my dentistry with Jeevan.
Right. Yeah, hi. I just wanted to know that after you finished your case with the patient who had recovered from from COVID, did you feel the need to undergo self-isolation at any point of time, or do you advocate self-isolation at any point of time during these times?
So you mean if my patient has COVID, what will I do? Is that your
you
question?
did operate on a patient who had recovered from COVID
in the past? Okay, yeah.
At that point of time, did it ever occur to you, or did you feel that probably you would be better off going in for self-isolation?
No, we had screened her. We did a swab test that came back negative. We used all the standard PPE that we have, so every time the interaction was there, we were protected. If I'm in hospital, if I've operated, the first thing I do when I come home is to get into the shower straight away. It's all. I was reasonably happy to not to do anything different than a patient that I treat, because she was COVID negative on the screening, and the history was very clear that she had some symptoms that sounded very much like COVID in March, and I operated on her in May. So, yeah, one thing I could have done was.
Do you recommend a sort of a 15-day on-off protocols for people who are on a unit where you get a breather? Do you recommend that?
Again, it comes down to resource management, Jeevan. If you have very limited resources, then then doing that 15 days off and on is not possible. But if you have the luxury of having that amount of workforce that can be curtailed down, and make it 15 days rest for them, and try and keep them isolated. Yeah, it's not a bad idea. And as I said, there's no one solution that fits for all healthcare systems. But it is an idea that makes sense.
Thank you.
Satheesh, there is a question. Hello.
Yeah.
From Dr. Hazare. What is the role of metronomic chemotherapy in wait-listed patients for 3 months?
I think the chemotherapy and these things, obviously these are all in I would say study and research base, and in fact we stopped all the research for the peak from March, April, May. So we haven't tried anything new or different. Yeah, we haven't tried anything for people who are waiting, because chemotherapy reduces the immunity, and we were quite concerned not to try anything new.
Okay. Abhay, can I ask?
Yeah, sir. That is what I have. Any questions you have, please?
Yeah. So, I would just generalize a few questions, Satheesh, that we want to know about fellowships in the UK. And secondly, if you could just briefly talk about your journey. I know for one that you were a very diligent person who had his ideas very clearly set out what you want to do. because I was in the GDC when you had just joined. So,
But actually, for his journey, we need to take another
maybe
webinar.
let's dwell upon it.
Yeah. No, I think I'll answer your first question to start with in terms of fellowships in UK. UK is a healthcare system that's always been seen as the epitome, but obviously we haven't done that well in the pandemic from the numbers, but that's for a different reason. But doing a fellowship at the moment in UK for from a maxillofacial point of view or from head and neck cancer point of view is based on if you have a medical degree or not. And that has been the case for the last, I would say, couple of decades. If you do come to UK and if you are done an MDS, then you're likely to do less work. You will pick up lots of soft skills and how to manage patients and various other things that from this healthcare system. But whether you will pick up any operating skills, I'm not sure. That's because the limited training opportunity for singly qualified has always been an issue. What I would suggest is, you got a lot of talent in India. I would suggest, go to different units, places like Nagpur, which I still find it fascinating to go and see the pathology and the surgeries they are doing. Go and visit different units within India. And then if you want to come and visit UK as an observer to see for maybe 2 or 3 weeks, to see how things are done differently. I won't say it is better or worse. It is just to see how things are differently and pick up a few things and go back and practice. And that's what I would recommend. I think India has come a long way. When I left India 20 years ago, was a different healthcare system. It has come leaps and bounds. I would definitely recommend you to go and visit a healthcare system, and that I would recommend it to myself as well, because there is a lot to learn from every system that we go and see. So I would definitely do that. Fellowship, a formal fellowship is a bit of a challenge. That's my honest answer. You're very welcome to try, but the chances are small. You won't get a formal training. Your second question, journey, Rama, I think if I can do, anybody can do it. I come from a very simple background. I had 2 pairs of clothing when I did my dentistry in Chitradurga. I'm sure Jivan will know. And I was not the most eloquent or sociable person. But the only thing I knew was that I wanted to do things that would make me a better person. And that journey has been the case all throughout, even now. There's a lot of things that I could have done differently. But one thing that I would tell the colleagues out there who think I've achieved a lot or done something amazing, that's not the case. I think you do everything right every day, and then you wait for your opportunity. And if you, I've just been fortunate enough to, do it right, I think that's all. But it's anybody can do it, that's for sure.
Yeah. So thank you, Satheesh. Sir, Shanoy sir, I will take the last question and then we can wind up.
Yeah, sure.
Yeah. Satheesh, can you elaborate, because there are many students also in this particular webinar today, like what are your thoughts about the post-operative care and the rounds, especially in this particular COVID pandemic? Like you spoke about a few in your presentation, so that it will be helpful for everybody.
I think staying alert is the key here. My sort of take on seeing patients hasn't changed, in the sense, if I operate on a free flap, I want to go and see them in the first 2 hours, whether I finish at 10 o'clock at night or 11 o'clock at night. I try and go and see them, because that is when there is always a problem. Usually my registrars know it. They do keep an eye on it. The drains may not be working. The flap might have a problem. So they're the sort of things. In terms of post-op care, if my registrars are involved, they're expected to see my patients. But given that PPE is an issue and trying to reduce the risk of infection, we try and appropriately see them. There's one person will go and see the patient who is able to manage everything. If it is registrars on the day who's going to be there for the rest of the day and going to manage, only that patient will be able to see the patient, and that's how we try and do it. But we do take photographs, which is quite easy. We try and get access to all their vitals and all on our laptops. So that way it has become more and more digitalized.
Yeah.
Nothing to replace clinical examination. And if I have a doubt, I won't hesitate to go myself and see, because if you catch the problem early, you're likely to solve it sooner and safer. So it's not that we will see them less, we will still see them, but in a way where we are going to use less PPEs. And when we do examine them, do a thorough exam. That is the key.
Yeah. So
I think.
Can we conclude the session, sir? Shanoy, sir?
Satheesh, can you stop sharing, because I have a duty to do?
Yes.
Thank you so much.
Sir. Satheesh, hello.
Yeah.
I would like to thank on behalf of Central India Academy of Oral and Maxillofacial Surgery for your wonderful, lucid and illustrious presentation today. You have given a lot of tips to all of us, especially like one-stop clinic, which I like very well, where the patient's exposure and our exposure also can be minimized. And you give a lot of wonderful tips for managing the patient in this particular COVID-19 pandemic, which I'm sure will be useful for other maxillofacial surgical procedures also. Thank you so much once again. And I thank President and Secretary for giving me an opportunity to moderate this wonderful session today. Thank you so much.
Thank you, Abhay. Thank you, Satheesh. We are indeed very grateful to you for having come in so early. And this is just a small token of appreciation from all of us from the Central India Academy. And this is for you, Satheesh. I will be sending you it across through WhatsApp or mail. And Abhay, thank you so much
Thank you
for your sharing. So for your moderating, sorry, I'm so sorry. So thank you, Abhay. Thank you, Satheesh. And we'll see everybody tomorrow at 11. We have Dr. Chandrasekhar Bande speaking on CA mandible. So please do join us. The link would be put up very soon. Thank you so much. The password remains the same. Only the ID changes. Thanks, Satheesh. Say hi to Aparna and your kids.
Will do. Thank you, Rama. Same to you. Okay. Take care. Thanks, Abhay. Bye-bye.
Bye. Thank you.
That's the feedback we've got. Thanks, Abhay. Thanks, Rahul, everybody.